Welcome to Action on Pain, a podcast dedicated to highlighting the significant efforts underway in Canada to address chronic pain.
By presenting perspectives from individuals who live with pain, researchers, clinicians, and other stakeholders, we explore various impacts on people's lives and the initiatives, research endeavors, and the committed professionals working to effect meaningful change.
This work is guided by Health Canada's Action Plan for Pain. Join us as we raise awareness and share stories that are shaping the future of pain management in Canada.
Welcome to Action on Pain, the podcast where we explore the landscape of chronic pain. I'm Virginia McIntyre, and as always, I am joined by Keith Meldrum and Jennifer Daly-Cyr.
Today, we are very excited to welcome to our podcast Dr. Norm Buckley. Dr. Buckley is a professor emeritus in the Department of Anesthesiology with the Michael G. DeGroote School of Medicine at McMaster University in Hamilton. Dr. Buckley established the Michael G. DeGroote National Pain Center and has been the scientific director since 2015. Furthermore, he is the nominated principal applicant of the Strategy for Patient-Oriented Research's funded Chronic Pain Network. Dr. Buckley brings a wealth of knowledge and a very unique perspective on the action plan for pain in Canada. Huge thanks to the Chronic Pain Network for providing our podcast with financial support. Norm, thank you for taking the time to be with us today. We are very excited about our discussion with you.
Well, that's our pleasure. And thank you for putting this together. And I'm looking forward to chatting with you all.
Welcome, Norm. So, Norm, you have had such an important role in Canada regarding pain treatment, pain research, guiding policy in Canada. So, I want to know if you could tell us a little bit about your work, but can you tell us also a little about the history of pain in Canada? So, some things, there's a lot that people just don't know.
Mm-hmm. Oh, my goodness.
Where to start, right?
Well, yeah, no, it's really quite interesting. As you say, and quite frankly, I've been on faculty at McMaster since 1988. I've been involved in chronic pain care as well as acute postoperative pain management and anesthesia, and for pediatrics and adults, and some little bit of dabbling in palliative care as well, more from the point of providing technical support to the palliative care physicians. But so, as I say, well over 30 years. And the last 5 to 10 years have been the most exciting times, I think, in that arc because of the amount of attention that has been focused on the problem of pain, and especially chronic pain. Sadly, a lot of that focus came because of the opioid crisis and the recognition that opioids were, virtually always, apart from when they're prescribed specifically for the treatment of addiction, opioids are almost always written as a prescription because of pain. And, we set out to try to treat pain, but with relatively small number of tools in the bag. And opioids assumed perhaps an overly large focus, but also we weren't very knowledgeable about doses.
Mm-hmm.
But, it's one of those bad news, slightly better news things. When people started to realize that there were a lot of opioids in circulation, one of the questions that was asked was, why do physicians prescribe opioids? I mean, most of us are not malicious or too weird as a rule. And, our intent is to try to provide care, solve a problem.
Mm-hmm. Yep.
But one of the other things that happens, and this goes back quite some time. In fact, you can track it back 50 or more years ago. There was realization, particularly in some areas in Europe and also, John Bonica in the United States, state of Washington, recognized the multiple elements of pain, of chronic pain especially. So not just the physical, you've had a physical injury of some sort, and the John Bonica story is interesting. He was apparently a wrestler. Oh. He went through medical school, but he put himself through medical school doing professional wrestling became intimately familiar with musculoskeletal pain and injuries and wear and tear and things like that. And it gave him a bit of a focus.
Wow.
But
Lived
he
versus practice.
lived
Yeah.
experience. I
Yeah.
mean, he was not just a leader in the pain care and research field, but he was a driven by personal experience and understanding of the processes. You know, he was one of the first people to systematize the idea of this, what we call the biopsychosocial model of pain. You know, a biological problem, physiological injury, surgery, trauma, something like that, or an illness that damages your nervous system, along with your underlying psychological state, the way you interpret your own health, physical symptoms, things like that, as well as the social setting in which you live and things that may drive you towards recovery or away from recovery. You know, things like compensation for injury, disability coverage, things like that, that on the one hand are helpful, but sometimes they drive people to, or they don't support recovery. Let's put it that way.
Yeah.
So, you know, he recognized that. From a personal standpoint, we have actually had an interdisciplinary pain clinic running in affiliation with McMaster University for 50 years.
Wow.
It
50.
was start 50 years.
50.
It, 50. It was very interesting because think about McMaster University Medical School was established in the late 60s, early 70s. And some of the early faculty there had, you know, a variety of interests. In fact, one of my mentors early on was an anesthesiologist named Jay Forrest, who was for a time, he had a number of roles, but for a time he was chair of the Department of Anesthesia. But he was also an anatomist and a pain clinician who made extensive use of regional anesthesia techniques in treating pain states, both acute and chronic. And he worked with a psychiatrist named Eldon Tunks. And Eldon Tunks had learned about Bonica's approach to pain, the interdisciplinary approach, and it fit into the conceptual model that the McMaster Medical School founders were trying to bring to their approach to medicine. You know, the interdisciplinary approach, breaking down barriers of care, you know, bringing different professions as well as different specialties together for common goals to solve complex problems. And so they, along with a bunch of other people, including some nursing profs, some physiotherapists, occupational therapists, psychologists, built a interdisciplinary chronic pain clinic that operated within the provincial healthcare system at the time. So now we're into the mid 70s now, mid to late 70s. So I started medical school in 1979, and I had an interest in pain. I'd come from a psychology background. My undergraduate degree was in psychology. Psychologists are known throughout the world as leaders in research and also treatment of pain, especially chronic pain. The combination of, you know, the concept of psychophysics, how do you measure sensory properties, but also understanding how the mind works to interpret your sensations and reasoning processes and learning and behavior and things like that. So it was interesting. As an undergraduate student, I learned some of these things also. I used to suffer from migraines for many years. And so it gave me a little, you know, on a scaled down basis, experience with pain states which were not threatening in a sort of biological sense, but were really, really annoying and made it hard to do things frequently. And so not much great treatment.
And I'm glad to hear it used to be that way for you.
Well, it didn't, you know, that's kind of a long journey. I had them well into my clinical practice and finally discovered vitamin B supplements. Also got to a state where I was not having to do call third or fourth night, and sleeping regularly seems to have a remarkable
What a
In fact,
surprise.
not
Yeah.
for you. But also volatile anesthetics. We used to give a lot of mask anesthetics, and you get anesthesia gases floating around the room. If I had to do a day of cases of all short cases with mask anesthetics, I would have a brutal headache by the
Oh,
end of the day.
Oh, that's very interesting.
And yeah, what I discovered is that you can give anesthetics with a migraine, but you cannot be a pleasant, happy person. You are no fun to talk to.
Anybody has migraines probably saying that. That's
Yes,
a challenging one.
that's right. Anyway, so I mean that's kind of my personal entry into the system. I discovered during my medical school elective period, did an elective with a neurosurgeon who happened to be a consultant to this interdisciplinary pain clinic and was also doing a lot of radio frequency procedures for trigeminal neuralgia, tic douloureux, and it was it, it was first of all, it was a remarkable technical thing to watch him do these under sedation because you had to wake the patient up after you positioned the needle to stimulate it to make sure it was in the right place, and then you'd put them back to sleep. So it was a neat. It became interesting to me later on because I realized how challenging the anesthesia was, but also it was neat to work. And so I worked with him to summarize all of his cases at the time to do a presentation at the Royal College surgery meeting. And he'd done about 80 cases at that point. And for trigeminal neuralgia, it was fabulously effective. So I was thinking, wow, this is really interesting. There are things you can do for these chronic pain problems. So when I went into anesthesia, anesthesia is the only Royal College medical specialty that requires that you do training in chronic pain management.
mm,
Right.
So I had
Yeah.
a 1 month rotation. And as I say, we were fortunate that we had access to really good pain treatment programs. I spent a month working in clinic with Dr. Forrest and several other folks doing pain treatment as a resident. And I went to Stanford University for my final year of anesthesia training. It was an interesting opportunity in the history of anesthesia, program changes in the United States, that a senior resident from Canada could go down and train there. And that was applicable to my Canadian anesthesia training. But they also had a pain clinic that was led by a Canadian named Lauren Elderington from Vancouver. But while I was there, I arrived there and discovered that they had a visiting professor for a year who was Michael Cousins. Now, in the pain world, Michael Cousins is just renowned. He has been the president. Well, he's recently passed away. He passed away just about a year ago now. But he was a leader in acute pain management, in provision of techniques. He wrote a classic textbook called Neuroblockade in the Management of Pain. He was the leader of the IASP, and he was one of the primary drivers for developing the pain strategy in Australia, which is a really well developed.
Yeah.
In fact, the strategy we looked closely at when we were trying to establish a strategy in Canada for how we would pursue, developing a Canadian pain strategy. So
Right.
Michael Cousins was there. It was freaking brilliant.
wow.
Talk about blind good luck. And I ended up doing 2 months in their pain clinic with Michael Cousins. But also, the folks at Stanford were using some pretty advanced post-surgical pain techniques, using epidural analgesia. And people would go out to the ward with an epidural running, and they'd walk around on, hours after your major surgery. The
Yeah.
first time I'd ever seen a patient following a thoracotomy who could wake up on my anesthesia table and move themselves to the stretcher. So, yeah, opportunities like that were remarkable for me, were personally remarkable. But it always also, we were able to bring some of that expertise back to Canada and built an acute post-operative pain service in 1987, 88 at McMaster. And I think that was the first time a university surgical program had that kind of care available to them in the country. It wasn't that people weren't doing it occasionally, but we were actually able to get it into the system. And it was quite remarkable, but we also started to see, from an acute pain standpoint, we started to see that, everything doesn't always work for everybody. And,
Imagine.
that
Yeah.
you have to sort of be on the alert for how, doing things and then modifying them, responding to the individual patients. But at the same time, hospital budgets were changing, and so that interdisciplinary pain program I told you about drifted into the third-party fee-for-service supported world. It was still
Right.
affiliated with the hospital, and it continued to run, which was remarkable. But it was third-party supported because the things like the social work and psychology and physiotherapy and so on were not able to be supported from the hospital budgets by then. But the program continued to run, and we also had sort of OHIP, like provincially supported individual physician pain clinics that operated within the hospital. And that sort of thing happened a fair bit across the country. I mean, and so a lot of pain care was delivered by anesthesia providers, frequently solo providers, who would focus on the interventional side of care and
Yep.
somewhat on the pharmacologic side of care, but not always being able to integrate the full spectrum of care because it wasn't necessarily available. There were freestanding community-based programs funded by third parties, a number of sort of rehabilitation-focused things for workplace injuries and post-motor vehicle accidents and things like that. And those things occur across the country to varying degrees, or rehab programs or rehab companies that would also do pain management. But, so now we're into the mid 80s, 90s, things like that. The Canadian Pain Society continually brought people together, and we would talk about what best practice pain management might be. And then I'm trying to think when it started. It was probably in the early 2000s. And there were by that time, there were a number of pain clinics in the country that were full-on interdisciplinary pain clinics, but they were kind of unique. I think the one at McGill may be the one that was hospital-based and survived, continued the longest. It has multidisciplinary programming there. There was one at Dalhousie. I'm not quite sure when it got started. Mary Lynch and John Clark were the people that I recall. They had a number of people through there, and they provided a whole range of interventional care. But Mary Lynch was a psychiatrist and leader of the CPS. They provided the full biopsychosocial model of care, and it was funded within their provincial health setting. But over time, again, funding for those things declined, and that clinic still functions, but I'm not quite certain about the range of services they always have access to. Quebec, it's funny, since we got into the chronic pain network and relating to people nationally, I've discovered more and more about Quebec. But that language divide, the two solitudes thing that I thought was solved because I read about it in high school, it turns out it still goes on. And one of the very funny things was talking to and one of the researchers in Quebec who said, "Oh yeah, in Quebec we collaborate with everybody. We collaborate with France, we collaborate with North Africa, we collaborate here. The only people we don't collaborate with is the other 9 provinces."
Oh, great.
Those silos.
Yeah.
No, it was very funny because
Yes.
Quebec is easily 10 years ahead of the rest of the country in developing their provincial pain care plan, the organization, the AQDC, the patient group, the QPRN, the Quebec Pain Research Network, and the ADQ, the professional association. So Association Douleur de Québec, or Québécoise, perhaps. But so they have the 3 necessary groups to support, and they're actually provincially supported.
Yeah.
So, and Quebec's, as I say, is at least 10 years ahead of the rest of the country in this.
So we could learn from
You
them.
rarely hear about, oh God, yeah. And talk this morning we had from Regina Visca at McGill about their digital platform supporting pain care. Brilliant piece of work that she's been working on it for 7 or 8 years, but it's a part of a much longer thing, and it's supported provincially as part of a digital strategy. I'm trying to edit this conversation into some kind of sane organization.
What fascinates me is you talk about these systems, these clinics that go back, 50 years. And I look at my own personal experience. My accident was in 86, and out in the West, there really wasn't anything. I was just handed around from solo practitioners who would stick a needle in me and say, well, it didn't work, go away. But this is a bit of a kind of a loaded question. I don't think you have the answer, but 40, 50 years easy of interdisciplinary care. And we know how critically important interdisciplinary care
Yes.
is. And it's taken that long to translate that through this challenging road to what is now the action plan for pain. I mean, it goes back 50 years, and it took until like 2021 for Canada to wrap their arms around this. I find that staggering.
Mhm.
Well,
Great point.
there are some interesting complexities about it.
Mm-hmm. I
Um,
imagine.
One of them is, well, there's two of them. One is when services were being provided within the context of central budget, like in a hospital, for example.
Mm-hmm.
There were a lot of resources available, relatively speaking, in the 70s and 80s in hospitals, and interesting. No, it's true. And I'm not sure where the resources relative to demand started to fall apart, or what other cost items drove the budget in the direction that you started letting people go.
Right.
But for example, hospitals provided less and less of things like the psychosocial support, social workers, psychologists, OTPT, things like that.
The very thing that was
in the
required for the
hospital,
whole
in the
picture.
hospital setting.
Yeah.
Exactly. The very thing that's required to treat, the whole patient.
Yeah.
Things would be decanted outside the hospital. So you might have surgery and be discharged more quickly, which is beneficial from the standpoint of avoiding infection. The longer you're in a hospital, the more likely you are to get sick from being in the hospital.
Yeah.
And that's with the best intentions. It's just a product of being in that setting.
Yes. Yeah.
First, do no
but
harm.
also the sooner you're discharged, the sooner you start moving about more. And things like physiotherapy can be delivered on an outpatient basis. So a lot of rehabilitative surgeries were followed by outpatient rehabilitation rather than staying in the hospital for 2 or 3 weeks.
Right.
And we started anyway. The change in the sort of the flow of hospital care now. All your pre-assessment is done outside the hospital prior to coming in. You arrive in the morning of surgery, you spend 1 to 9 hours in an operating room, you wake up, you spend some time on the ward. As soon as you no longer need active parenteral treatments, you're discharged home. You're not ready to do anything else yet. You're still in the recovery phase, but you're recovering at home.
Yes.
Yeah.
Back to Keith's question about how is it that we didn't get the resources together. And part of it is, what are the drivers to do that? So one of the things that drives change in medical care is research into largely pharmacological or technical solutions for problems.
Right.
And then the need to market and distribute those things drives knowledge mobilization, which drives behavior. So when a new pharma product comes out, it's likely to enter into use fairly quickly and get shunted out. When you have and there are people with an investment in making that happen. Multidisciplinary care it's a problem for the healthcare system because it's another sinkhole to pour budget into when you have limited budgets. How do we decide to hire more people? How do we fund them? Even if you don't put them in a hospital, are you going to fund, through a provincial funding system, a psychologist or a physical therapist, for example? And then are you going to fund the team process? Because it's a resource-intensive process and it's not appropriate for everybody, but when it's necessary, it's brilliant.
Right.
But then the people who have an interest in driving that care out are the practitioners themselves, the psychologists, the physical therapists, chiropractors, whatever the discipline is. And of course, when they go to lobby for more funding to support their care, they're seen as being very conflicted, which of course they are.
Yeah.
And the challenge is deciding, what is the right thing to do in doing it. So I think part of the problem is there isn't a marketing process for getting those people into play.
Right.
Yeah, and so it really has to be a policy change. But to some extent, the budgeteers are terrified of complex, expensive care because they have limited budget, and everything new is more expensive.
And yet, in a
Right.
way, if they could sort of re-engineer that back to the more of an interdisciplinary approach across the board, they could probably get people up and moving and walking and recovering much more quickly, you would think.
Well, exactly. In fact, Fiona Campbell, past president of the Canadian Pain Society, pediatric anesthesiologist at Sick Kids, pain leader in the country, she looked at that exact thing. So the pediatric pain program at Sick Kids is expensive. It's complex.
Right.
It requires a lot of resources. But what she was able to discover is that when kids come to that program, their total healthcare costs decline. Because prior to coming to the program, what you described earlier, Keith, they get, they go to their family doc. Their family doc says, geez, I don't know, I better send you to this consultant. That consultant says, well, it doesn't really look like my business, but it might be this other guy. Try that. So you're 7 or 8 consultants down the line, plus a couple of nighttime visits to the Emerge because the pain is terrible and you're awake and you're missing school and so on and so forth. Then you get to an interdisciplinary program that collates all the information, sits down, explains to you what happens with pain, tells you the recovery strategy, works with you on the recovery strategy. Yes, it's expensive. And it takes 6-8 weeks of frequent visits and engagement to start the process, and then a long follow-up because you're at the point of changing behaviors. But you can get people back to school. For example, if you're a kid, you can potentially get people back to work if you're an adult and you haven't really disabled out of the workforce, which is, that becomes one of the social issues, right? All of the financial drivers that do not support recovery.
And Norm, I think in the long run, it saves money. Like I know myself, I was out for 3 years, and by the time I went to the clinic, I got back to work, so I'm not on a disability.
Yeah, well, you see, and that's the point I was getting to in a very roundabout way with the pediatric one, is when Fiona Campbell looked at healthcare costs, even with the added cost of the complex pediatric program, their net costs were less than patients with similar conditions that didn't end up in the program, and they were less than they had been experiencing prior.
I believe that.
Yeah.
So it's exactly the challenge is to pick off the right point to trigger the expensive system.
Yeah.
Right. Yeah.
Right. Everybody that gets low back pain, the Quebec low back pain study, a relatively recent thing, they've been tracking everyone in the province who reported an acute back pain episode. They were collecting the information from primary care docs and all of these, so they know how many people had acute back pain episodes, and then they followed them. Most of them get better if you don't do anything special.
Yeah.
Right? Most things, and it's like surgery. We have the capacity to be brilliant at post-surgical pain care. By and large, we're terrible at it. And yet 70 to 80% of people do not go on to develop chronic post-surgical pain. 20 to 30% on average do, varying a little bit depending on the procedure and so on.
Right.
And it seems, researchers in Canada, people like Luda Diatchenko, for example, who's holds a pain research chair in genetics at McGill, she's part of an international team that looked at the genetics of chronic pain. And it looks like it is a failure to recover, a failure of your normal recovery systems that leads to chronic pain, more so than an active continuing process.
Interesting.
Which really mean, and then in my head, that loops back to, well, maybe that's why these recovery-focused interdisciplinary rehab programs work, because you're not trying to stop a process, because there isn't a process to stop. What you're trying to do is relearn the normal recovery state.
Right. Right.
And so all of those things that seem counterintuitive, like when I have a migraine, for example, what do I want to do? I'll tell you, what I want to do is not personal reflection and exercise.
No.
That is very low on the list.
Right.
And yet, interestingly enough, the times I have had to, for some reason, walk somewhere or do some exercise or something, it often resolved more quickly than if I just, did the usual lie down on the couch, wait till I throw up, fall asleep for 6 hours, and then
Right. Lovely.
I'm fine but tired, right?
Do you think you just gave a great explanation as to like why this has been so challenging, and you just talked about, centralized budgets and just sort of really no overarching framework. Do you think the action plan for pain in Canada is at least the beginning of this at least higher level framework for healthcare systems across Canada to start focusing them in a direction so that they can better decide how to invest their dollars and know where the best it's got to be a return on their investment. And healthcare isn't business, but it is for the bureaucrats. I get it. Do you think the action plan will start to maybe give that direction so they're not just all running around willy-nilly trying to figure out what to do?
The hope is that people will pay attention to it because it is a federal government document. It came from Health Canada task force. It has been given the status of a national strategy.
Yep.
It provides the framework, and frameworks are a big deal for helping people to allocate their time and resources.
Right.
Also, I think it is starting to lead to other conversations where at the provincial care level, now clinicians, patients, advocates are going to the provincial healthcare systems and saying, look, there's a national plan. It says this is important. How are we supporting the national plan?
Yeah.
Yeah. Yes. And, so people want to get some check boxes, right?
Right.
And especially bureaucracy. We started out a little bit before I got completely off track talking about the history of pain stuff in Canada. In the mid 2000s, one of the things that happened at the Canadian Pain Society was a bunch of pain clinicians together saying, we all have this horrible wait list problem.
Right. Yeah.
And yet that was about the time that on the surgical side, for things like cataracts, total joint repair, open heart surgery, people started to recognize the importance of dealing with wait lists from a surgical side. And because many chronic pain clinicians at the time were anesthesiologists, they're sitting around listening to the surgeons go, oh, wait list, my life is terrible, woe is me. They said, wait a minute, we have wait lists too. And so that was Mary Lynch and John Clark's brilliant maneuver, was to enter the pain clinic wait list things into the national discussion around healthcare waitlists.
Interesting.
And that led to some of the early, collaborations looking at what happens to people on pain clinic wait lists, what happens if you have chronic pain for a long time. Yeah. And they initiated a whole wait list working group, and so I'm going to say 2006-07 thereabouts. And that informed, one of the things they did was to commission a deliberative dialogue with John Lavis's group, the McMaster Health Forum. So this goes back some time. We're now talking 2009 thereabouts. And John was really irked because he could not get the engagement of a single healthcare bureaucrat. And usually his experience in other areas where they bring evidence to bear on healthcare resource problems was that the bureaucrats are knocking at the door saying, we want to participate, we need to know how to proceed. In this case, pain wasn't on anybody's agenda. It was an interesting meeting, but I do remember noticing that he was irked about that. There was a follow-up several years later, which was funded by a grant that Jim Henry got. So he was my predecessor at the Institute here, but he got a grant called CART, Communities for Advancing Health Research or something like that. But they funded another deliberative dialogue. And for that one, they were actually able to bring somebody from Quebec, because by then Quebec had started to initiate its own pain strategy. And so they spoke to it. But it really wasn't a huge uptake again. But that was interesting because it sort of started to give some perspective about the problem of chronic pain and its complexity. And then remember, that's about the time that FEMRAC, the Federation of Medical Regulatory Authorities of Canada, created the first Canadian opioid guideline in response to the growing number of opioid prescriptions, but also accidental deaths associated with prescribed opioid use.
Right.
which were often being used in sort of illicit settings. They were either being
Mhm.
diverted or combined
Yeah.
with other drugs like alcohol, especially is the wicked one there.
Yeah.
And, so FEMRAC came out with their guideline that started to focus attention. The Canadian Centre on Substance Use and Addiction was charged with developing a strategy for addressing the opioid crisis. That came out in 2014. In 2012, Montreal hosted an International Association for the Study of Pain meeting, and in conjunction with that, held an international forum, which led to the Declaration of Montreal, which speaks
Right.
to the right to effective pain care being a human
Human
right.
right. Yeah, that's
So
right. Yeah.
that came,
Mhm.
so this is the timing,
Yeah.
right? All these
Mhm.
things are happening. Recognition of
Yep.
wait lists, starting to get pain clinics into consideration, opioids focusing attention, the Montreal Declaration, and the first cut at the Canadian Pain Strategy, which sort of flopped onto Parliament Hill around 2012, 13, 14, somewhere around there. And in part, it had a lot of support from clinicians, had a lot of support from patients and the public in general, had no support within the bureaucracy. Pain didn't
Mhm.
have any traction. And so
Yeah.
there was nobody to bring it to a minister's attention as this is within your portfolio, needs to be
Right.
addressed. It was just this nightmare sitting out front. So the Harper government at the time just pretended it didn't exist. There
Yeah.
were a couple of folks from the NDP and the Liberals who came out and said, "Hi, wow, this looks like a problem. See ya." And
Not
well,
touching that
so,
one.
so that went on, but now attention mobilization is starting to happen. But also, we had this funny group within the Canadian Pain Society. So we had the what we called APDOC, the Academic Pain Directors of Canada, and really it started out with the universities who had pain clinics, and a director within the program. We would all get together and have dinner and a couple of drinks and talk about how bad our lives were and what the challenges were, and talk about, Angela Malis was there, Mary Lynch, Pat Morley Forster from London, Dwight Moulin, a bunch of other, people from across the country who all had similar problems. And Kathy Smythe from Ottawa was there. She was the pain clinic director there at the time. And so this group grew up. And after a couple of years of relatively unfocused whininess and general feeling bad, a couple of things started to happen. So, for example, somebody said, well, we really need to have specialty pain training programs, don't we? And Pat Morley Forster ran with that, put together a group. We created an application to the Royal College of Physicians and Surgeons of Canada to create a pain medicine residency. It was the first new residency program that they had approved in 10 or 12 years. They were
Wow.
resisting adding new training programs.
Mhm.
And it was an add-on to a base specialty. So you could complete a residency in anesthesia or medicine or emergency medicine or whatever, pediatrics, and then come and do 2 years of additional training in pain.
Mhm.
Now recognizing that 2 years is a substantial burden, especially if your base program took you 4 or 5 years.
Mhm.
They've
Yeah.
allowed now, if you focus your training early on, you can sort of get credit for some of it, but it's still at least one year to 18 months.
Mhm.
But it is a specialty training program. You
Right.
end up
Yeah.
with certification as a pain specialist.
Yeah.
So that was an interesting and unique thing that came out of APDOC. The other thing that came out of APDOC was, in fact, the Chronic Pain Network. Because, again, it was a group of people that knew each other. When the opportunity came up, we were circulating information amongst the APDOC leaders, the APDOC members, and said, yeah, we should do this. And from my personal standpoint, I had come into the role as institute director at the DeGroote Institute at MAC, which meant I had full-time admin support and an excellent senior administrator who thought this would look more interesting than the job they had at the time. And they were also very experienced CIHR applications because they came from a very successful academic department that did a lot of CIHR applications. But, so this team, the APDOC group said, yeah, let's do this. Kathy Smythe sent off the registration just to make sure we were in line, and also confirmed with CIHR that pain was considered a chronic disease.
Right.
And of course, by that time, we're talking 2014 to actually 2015, the WHO had said, yes, chronic pain has the characteristics of a chronic disease. It's independent, independent of its originating problems. You know, it continues on, and it's not functional, and we don't clearly understand the pathophysiology.
And that's the ICD-11 or be pre-ICD-11?
Well, the WHO, it's pre-ICD-11.
Yeah.
Because ICD, the International Classification for Diseases version 10, had very limited issue diagnostic categories, which makes it impossible to search administrative data sets about pain.
Right.
So you get the pain researchers doing all sorts of funky workarounds to do things like looking at data from CIHI, the Canadian Institutes for Health Information, or in Ontario, ICES, the Institute for Clinical Evaluative Sciences, collates all of the healthcare data. And you can, if you have a disease which has an ICD-10 code, you can search those databases for your disease. If you don't, you have to say, okay, what might these people look like? Well, they might be on this medication, and they might see a lot of this kind of doctors, and they might, and then you put together an algorithm that pulls them all up, and then you go through, and it's really messy and hard. But, some people have done some interesting work at using those workarounds.
Right.
ICD-11 actually has chronic pain.
And so all of these, I mean, I almost visualize it as the cement bricks building a foundation, and how you've described this is kind of like, here we are, and all of a sudden you're ready to build the house with the Canadian Pain Task Force and the report that came from that.
Pretty much. I mean, different things were coming together in different spheres. And of course, my memory always tries to make sense out of seemingly unrelated events. That's what people's memories do. So I may be making more of a story out of it, but I mean, all of these things are consistent, and so things like the Canadian Pain Society, for example, that was the place where people got together and talked about these things. And so, and AppDoc, we have steadfastly resisted organization. We define ourselves as a nihilistic collective, and we have only one officer, which is the chair, and the chair's only responsibility is to find the restaurant where we will meet each year at the CPS. And then the meeting just unfolds. We do a basically cross-country checkup, what's going on with everybody.
Yeah.
But the amazing thing was, this past year, there were several of us, like myself, Angela Malis, Dwight Moulin, who'd been involved from very early on and very clearly remember the whining portions of AppDoc. And we listened to people from across the country talk about the new programs that had been initiated, the new resources that were available to them, the newly graduated pain specialists who had come to work in their place to lead a new pain program. And it was amazing.
Wow.
When I say things are entirely different now than they were 30 years ago, they are. I mean, the whole meeting was it was almost a happy meeting.
I think, Norm, that is a great way to wrap this up, because you've taken us the bookend. You started off telling us that things are, in the last 5 years have become so much better. And you have just provided so much richness into the last, 5 decades easily of how we got here. So on behalf of my co-hosts here, we absolutely thank you for joining us today, providing this richness and this fullness of all this that has gone on in Canada, which I know I didn't know at all. So it's been eye-opening and such a learning experience. And to have people like you who were the early trailblazers and who knew where this needed to go and just kept finding the way to get there means a lot. So thank you for joining us today and with your knowledge and your expertise. And I suspect we're going to be wanting to have future conversations with you.
Look, it's my pleasure. I'm glad you guys are doing this.
Oh, Norm, this was great. Thank you. And we'd also like to thank all of you who are tuning into the podcast, Action on Pain. We hope this episode has shed some light on the important work being done in Canada and the history around this work. Thank you, Norm, as guided by Health Canada's An Action Plan for Pain in Canada. Until next time, thank you.
Thank you.
Thanks, everyone. Thank you for joining us today on Action on Pain. If you enjoyed the discussion, please follow us on your preferred podcast platform to stay updated, and please share with your networks. A 5-star rating and review would help others find our show. Your feedback is important.
This podcast does not contain any medical advice. Please consult with your doctor if you have any questions or concerns.
The Action on Pain podcast is made possible by the generous support of the Chronic Pain Network, a national research and knowledge mobilization network.
The views, opinions, and content shared by hosts and guests are their own and do not necessarily reflect those of the Chronic Pain Network or its funders.